Hey there viewers, welcome back to our channel. Today we're diving into part 5 of our series on heart valve disorders, focusing on surgeries and treatment. Let's get started. Let's start with valvuloplasty. Valvuloplasty is a procedure where we repair rather than replace a cardiac valve. It's great because patients don't need continuous anticoagulation afterward. The type of valvuloplasty performed depends on the cause and type of valve dysfunction. There are different repairs methods like commissurotomy, which is done to the commissures between the leaflets, or annuloplasty to the annulus of the valve, repairs to the leaflets themselves, or the chorda by chordoplasty. Usually, a transesophageal echocardiogram or TEE is done at the end to check how effective the procedure was. Most of the time, valvuloplasty needs general anesthesia and often a cardiopulmonary bypass. But some can be done in a cardiac catheterization lab or a hybrid room without those. A hybrid room is super cool. It's an operating room with imaging capabilities like fluoroscopy, CT or MRI, and it's equipped for all sorts of procedures. Now, the most common valvuloplasty procedure is commissurotomy. Each valve has leaflets, and the spot where they meet is the commissures. Sometimes these leaflets can stick together, causing stenosis, or they might not close properly, leading to regurgitation. Commissurotomy is the surgery that separates these fused leaflets. In some places, especially developing nations, they do a closed commissurotomy or balloon valvuloplasty without cardiopulmonary bypass. The valve isn't directly seen during this procedure. It's often the go-to for patients with a specific type of mitral stenosis or those who could benefit from tricuspid valve repair. They make an incision and use a dilator to open the commissures. In the US, percutaneous balloon valvuloplasty is more common. It's used as a bridge to more complex surgeries, and it's particularly good for younger patients with mitral valve stenosis or those at high risk for surgical complications. These procedures involve catheters, guide wires, and specially designed balloons and is done in the cardiac catheterization lab. Patients might get light sedation or just a local anesthetic, and of course there are some risks. All patients will have some mitral regurgitation afterward, and there is a chance of bleeding, emboli, or even atrial shunts through the created atrial septal defect. Alright, let's continue our deep dive into heart valvular surgeries with a look at open commissurotomy. This procedure is pretty intense as it involves direct visualization of the valve. The patient is under general anesthesia and the surgeon makes either a mid-sternal or left thoracic incision. Once cardiopulmonary bypass is started, they make an incision into the heart to expose the valve. Then, using tools like a scalpel, finger, balloon, or a dilator, they open up the commissures. One of the big pluses of this method is that the surgeon can actually see the valve, which means they can spot and remove any thrombus or calcifications. And if there are any issues with the cordia or papillary muscles, they can be inspected and fixed up as needed. Next up, we have annuloplasty. This is all about fixing the valve annulus, which is where the valve leaflets meet the muscular heart wall. Most annuloplasties need general anesthesia and cardiopulmonary bypass. The goal here is to narrow the valve's orifice, which is super helpful for treating valvular regurgitation. There are two main techniques for annuloplasty. One uses an annuloplasty ring, which can be rigid, semi-rigid, or flexible. The valve's leaflets are stitched to this ring, creating an annulus of the right size. This ring takes on the tension from the moving blood and the contracting heart, which helps prevent the valve from regurgitation more over time. The other technique involves folding over elongated tissue onto itself or tacking leaflets to the atrium or each other with sutures. This method might not last as long as the ring because the leaflets and sutures are directly exposed to the blood flow and heart muscle movement. Moving on to leaflet repair. The leaflets of cardiac valves can get damaged by stretching, shortening, or tearing. To fix elongated or ballooning leaflets, surgeons remove the extra tissues. They might tuck and stitch elongated tissue or cut out a wedge and sew the gap closed. Short leaflets often get a cordeoplasty, where after releasing short cordia, the leaflets can work properly again. If there is a hole in a leaflet, it can be patched up with a piece of pericardium or a synthetic material. Now, let's talk about cordeoplasty. This is all about fixing the cordia tendinea, which are most often a problem in the mitral valve. The tricuspid valve doesn't usually need this because its issues are often due to other valve disease or left ventricular dysfunction. Stretched, torn, or shortened cordia can lead to regurgitation, so surgeons might shorten stretched cordia, reattach torn ones, or elongate shortened ones. And if the papillary muscles are stretched, causing regurgitation, they can be shortened or moved. Let's talk about valve replacement. When fixing the valve isn't an option, like when parts of the valve are stuck together with calcifications or fibrosis, we have to go for a replacement. A team of experts, including cardiologists and surgeons, work with the patient to figure out the best approach, whether it's traditional surgery or something less invasive. For most valve replacements, general anesthesia and cardiopulmonary bypass are needed. The usual way to do this is through a cut down the middle of the chest, but sometimes, especially for the mitral valve, they can make a smaller incision. Some valve replacements can be done with minimally invasive techniques, which means less pain and a quicker recovery for the patient. And guess what? Some of these procedures are even robot-assisted. Once the valve is out, the new one is put in place with sutures, and then it's all about making sure everything's working with a special ultrasound called a color flow Doppler TEE. There is also TAVI, which is a less invasive way to replace the aortic valve. It's done in a cath lab or hybrid room, and it's perfect for patients who can't handle the stress of open heart surgery. They use a balloon to make space and then put in a new valve with a catheter. And for mitral valve issues, there is the Mitra clip, which is great for patients with severe regurgitation who are at high risk for surgery. Now, after the surgery, the heart has to get used to the new way blood flows, which can lead to some complications. But usually, these new valves work great and don't mess with heart function too much. Let's not forget about mechanical valves. These are super durable and are often used for younger patients or those with certain conditions like kidney injury or infections. They last a long time, but the downside is that patients will need to take blood thinners for the rest of their lives to prevent clots. Let's keep the momentum going and talk about tissue valves. These come in three varieties: bioprostheses, homografts, and autografts. They are less likely to cause blood clots compared to mechanical valves, and the best part is no need for long-term blood thinners. But they do have a shorter lifespan and need to be replaced more often. Bioprostheses are tissue valves used for replacing aortic, mitral, and tricuspid valves. They are not prone to causing clots, so patients can skip the long-term anticoagulation therapy. They are a good choice for women who might get pregnant because they avoid complications related to bleeding, fetal transfer, and childbirth. They are also suitable for people over 70 or anyone who can't handle long-term anticoagulation. These valves come from pigs, cows, or horses and can last between 7 to 15 years. Homografts or human valves from donors are used for aortic and pulmonic valve replacements. They are harvested along with the bits of the aorta or pulmonary artery and kept super cold until needed. They are not always easy to get and can be pricey, but they last about 10 to 15 years. Autografts are pretty cool because they use the patient's own pulmonic valve and a piece of the pulmonary artery to replace the aortic valve. No blood thinner is needed here since there is no risk of clotting. They are great for kids since the valve can grow with them, as well as for young adults and anyone who can't take blood thinners. These can stay good for over 20 years. Most of the time when they do an aortic valve autograft, they also replace the pulmonic valve with a homograft. But if the pressure in the pulmonary vessels is normal, some surgeons might leave the pulmonic valve alone. Turns out you can actually get by without a valve between the right ventricle and the pulmonary artery. And that's the wrap on last part of heart valve disorders. If you've enjoyed this series and learned something new, make sure to hit that like button and subscribe for more health and medical content. Thanks for watching, and I'll see you in the next video.